Hi, I'm Lydia with Revelation Real Estate, and today we have two amazing partners with us. We have Battalion Chief Jesus Ramirez with the City of Surprise.
Rivera,
I'm so sorry, Rivera.
Okay.
And Rebecca Rocho with Dispatch Health. Thank you for coming. And what I'm so excited about with this podcast today is that you guys have partnered with each other as far as you are paramedic firefighter and you have mobile urgent care.
Mm-hmm.
So I know we've got a lot to talk about today. So give us kind of what are some of the bigger calls that you get? What are the most calls you get for the City of Surprise as far as urgent calls are?
Sure, yeah. City of Surprise, like other agencies throughout the Valley, fire departments, majority of the calls that we get are medical related, medical in nature. A lot of them minor injuries, falls, ill people that aren't really sure what's going on and not really sure who else to call. So we respond to those and provide them with what they need after an assessment and then provide them with options.
Right. And as far as Rebecca, Dispatch Health gets a lot of calls as well. What are some of your bigger calls that you get?
we respond to the same types of things.
Okay.
So a lot of colds, flu season's going to start early this
Yep.
year. UTIs in our elderly population. We see ages 3 months and above.
Okay.
So we can see, fevers in young children. We can see UTIs in our seniors. All different kinds of things.
Right.
And
dehydration.
exacerbations of CHF, COPD, diabetes, things like that.
Okay. So as far as the both of you together, you've got some programs that you're working with. So give us, one is obviously the first program you have through the fire department is the ambulance emergency response. That's just your everyday call. Is that kind of...
Yeah, typically when somebody calls 911, the first unit they're going to get is a fire engine.
Okay.
It has 2 paramedics and 2 EMTs on it. We're going to respond, and it's sometimes with lights and sirens, a lot of times without, because if it doesn't seem to be a life threat on the 911 call, we'll just drive out there normal. And we get there, do the assessment, ask some questions, do an evaluation. We always put them on a heart monitor so we can look at a 3-lead, if needed, a 12-lead view of their heart, vital signs, blood sugar, temperature, physical assessment, listen to lungs, things like that, to try to identify what they have going on. And then with the questions, we figure out what they have in their history that could be causing their condition. If it's something new and unrelated, that's always concerning. And that's always a situation where we'd want to transport somebody directly to the hospital in the event they're having some type of life threat.
Right. So another program that you have, you call it Treat and Refer program. So let's kind of dive into that one. So that is a program where you'll get your call and you do the assessment, and then what do you do after that? What's kind of the referral that you're doing at that point?
Sure, yeah. So they start out the same way. It's a 911 call. We respond in a fire engine. We do the assessment, the initial medical care where we vital signs, do all that same thing, questions, 2 sets, and try to figure out what's going on with them. Now, if we identify that it's not a life-threatening situation, it might be something like they have low blood sugar, or they're a bit dehydrated, or they're having a mild allergic reaction, or a mild asthma respiratory situation. We can provide them with treatment on scene, do a reassessment. If they show improvement, and a lot of people do, a lot of people feel a lot better after they get that initial care that we provide, and we still find that they have no life threat, then we would go to that situation where we could make a referral. So we try to figure out what's best for them in their condition. If they're having a situation where they could go to an urgent care, we would recommend urgent care. For some of the senior population, it may be late at night. Maybe they don't want to drive to an urgent care. Maybe they're not familiar with an urgent care. They've never been there, and they're only familiar with the emergency room because they've driven there, or we've taken them by ambulance. So then we make a recommendation. Hey, we have this service. It's a mobile urgent care that can come to you. These folks work with us. They bring a nurse practitioner and an EMT, and they'll provide you an assessment. If you need a prescription, they can
Right.
get that going for you and provide you a higher level of care.
Okay.
Does that sound like something you'd be interested in? And
Right.
most people, once they hear about it, they're like, yeah, I can just stay
Yeah.
here. And it's like, yeah, just answer the door when they arrive, and then they'll provide you with an appropriate level of care. So that is one option, and that's how
Okay.
we've partnered with Dispatch Health.
Okay.
There are some other situations where maybe they need to go back to their specialist. A diabetic patient should definitely go back with their specialist and
Okay.
figure out what's going on there. If they're suffering from behavioral crisis,
Right.
then we'll make sure that they get into a behavioral program. If
Okay.
they're an immediate threat to themselves or others at the time, danger to self, danger to others, then we provide them with alternative transport directly to a behavioral facility. There's a lot of adult facilities that we work with that they receive funding from the Regional Behavioral Health Authority, so they don't
Okay.
get billed for that.
Okay.
And
And do you do those assessments while you're there? You figure out which
Yeah.
which way to send them, basically.
Yeah. We identify what would be the best resource for their needs at that
Okay.
time. If it's not ambulance to a hospital and there's better options,
Right.
we're going to run those options by the patient,
Okay.
explain to them what they are to get their consent. Because people, if they want to go to the hospital by ambulance, we'll take them that way.
Right.
But we provide them with these other options, and they're really surprised when they do receive these options and they go to these other services,
Right.
and they get the care they need immediately. So like a behavioral health patient, they would spend, when we first started our program in 2015, they would spend anywhere up to 24 to 72 hours in an emergency room just waiting for care, waiting
Right.
to get that behavioral health service that they
Right.
need. So since we've developed partnerships with different behavioral health facilities, we can get them directly there, and within a matter of 10 minutes, 20 minutes, however long it takes us to get there, they'll be in touch with the behavioral health provider immediately. And one of the bigger challenges we have is with adolescents as well.
Okay.
Anyone that's under 18,
Right.
there's a lot of teenagers that have a lot of challenges, and so we want to get them in touch with those services as well. So we've partnered
Absolutely.
with several facilities throughout the valley where we transport them to as far out as Chandler to
Oh,
ensure
wow.
that
Okay.
they get immediate care.
Okay.
We don't want to let anyone fall through the cracks there.
Right, right. And it's probably helped the municipality to basically go to some of these other resources than constantly going to the emergency room, because they're overrun at certain times of the year. Obviously,
Yeah.
our winter time gets a little more full because of all of our winter visitors, and so these probably have made it a little more affordable and also get the help faster, it sounds like.
Definitely. And what happened is when paramedics first started in the 70s and ambulances were created, the protocols came from medical directors, doctors within the hospital. So
Okay.
a paramedic is an extension of a doctor. We can do a lot
Right.
of the same treatments and procedures out in the street that they do in the emergency room.
Right.
And so for many, many years, it's been the only option we've had is to
Okay.
transport them to the hospital. The guidelines, the protocols have all said transport to the hospital.
Yeah.
And the only method we had to get them there was an ambulance.
Okay.
And so for many years also, the only source of sustainability or any type of revenue that an emergency agency would have is transport to the hospital.
Right.
Although state statute allows transport to other destinations when
Okay.
appropriate, the only reimbursement was for a hospital.
Gotcha.
So that created challenges where we really,
Right.
over many years, a lot of firefighters and paramedics were just kind of, they love what they're doing, but just
Right.
kind of disappointed that we didn't have better
Right.
options to provide to people.
Yeah.
And it just wasn't part of protocol, and we'd be kind of going rogue if we did anything without that.
Right.
So since the Treat and Refer program was developed and approved by CMS in November of 2016,
Okay.
that is really the first time, and specific to Arizona, that CMS has recognized a paramedic for their level of training, education, professionalism, expertise, where we can assess a patient and identify a life threat, provide treatment on scene, and then recommend transport or referral to another facility by some other sort of transport.
Okay.
And so the group that really the payer that started supporting this first was Access, so
Right.
Medicaid.
Okay.
Medicaid supports it. So Treat and Refer is Medicaid funded, and it really depends on the payer mix in the community. If you have Medicaid, then we're eligible to receive some reimbursement for that to help offset the cost for
Right.
the IV supplies, the medications, the
Right.
electrodes that we use for the EKG and blood sugar and things like that.
Right.
So we really have been working to try to get other payers on board, like
Okay.
Medicare and
Okay.
private insurances, but it's been a little bit of a struggle.
I'm
It
sure.
takes some
I'm
time.
sure.
Yeah.
Are we the only state that has a program like this? Is this unique to Arizona?
It is unique to Arizona. There are other states that are working on similar programs with their Medicaid.
Okay.
But again, it's challenging. Not everybody joins right away because if they have a high Medicare population, there's
Yeah.
not really any sustainability in that program.
Right.
And working for a government agency, we want to make sure that the program is sustainable,
Right.
along with providing the best
The service.
level of care.
Right.
Yeah, and so the way we do things, most fire departments do, municipalities, is we don't screen insurances. We don't say,
Okay.
hey, what insurance do you have again?
Oh,
And-
okay.
And then provide you options
provide
there.
service
We
to
provide-
everybody.
Yeah, so if you're
Okay.
Medicare, if you're uninsured, if you have private insurance, you're going to receive the same level of care that everybody's
Right.
going to get. We
Right.
don't do the wallet biopsy or anything
Right.
like that.
I think that's how, isn't that how the hospitals do it too? Because I know my daughter has said that they have to provide service for everybody that comes.
Yeah,
to
they
as
have a
well.
law. It's
Yeah.
called EMTALA. And so
Yeah.
when someone goes into an emergency room, they have to receive care.
Provide it.
Yeah, yeah.
So with this program, you basically are the eyes and ears, because normally someone would call you, dispatch health, say, these are my symptoms, but you're not really there. I mean, you have a good source of questions to ask them during that time. But the paramedics and the firefighters are kind of your eyes and ears too, seeing what the symptoms are ahead of time before you even get there. Is that kind of, yeah.
Exactly.
Okay. And how long this program between the two of you, it's been going on since 2016? No.
No. So he's talking about treat and refer.
Oh, okay.
So we've just started to work together.
Okay,
to,
okay.
You know,
How
help
is
with them
it-
on scene.
Okay, so you guys just they are just one of your referral sources.
Right.
Yeah.
So how has it worked for you guys? For
It's-
both?
Yeah, I can speak for us. It's been great. I
Okay.
think so part of the treat and refer program is follow up. We want to know within 72 hours, did that patient go to an emergency room
Right.
anyway? Did they follow up with the care that we recommended?
Right.
And so we do that through there's different ways we do that. We send out surveys, so we collect email addresses
Gotcha.
and phone numbers on scene. Not something that we would do in the past. If we
Right.
asked for a phone number, it could be considered a little bit creepy, but
Right.
but it's required now, and so
Right.
that way we have a way to follow up with them. If they don't have an email address, we can call them. And so we want to know, did we help them out? Did
Right.
we consider their thoughts in that treatment plan? Did
Right.
treatment plan, did it work for them?
Right.
Did they understand the plan that was recommended for
Right.
them? Would they have called an ambulance and gone to the hospital if this service didn't exist?
Right.
And would they use it again? And are they satisfied with it? And we have a really high satisfaction percentage. Most
Okay.
people really love having options. They
Yeah.
really like knowing that they could go to an urgent care or
Right.
they could make an appointment with their doctor.
Right.
And most people, after receive treatment and IV fluid, sometimes they feel a lot better right there. Like,
Right.
oh, I don't feel like I need to go anywhere.
Right.
But we still make that recommendation because we're not doctors. We're just
Right.
that navigator that wants to make sure they get the appropriate level of care.
Right. So you follow up with them within a day or two and try to make sure that they've either been to a doctor, gone to an urgent care, or whatever situation they have to go to at that point. Do you find that the majority of those folks do make it to whatever facility they need to go to? Is that a high percentage?
Yeah, a lot of people do. Some said, no, I just wanted to stay home. I felt better.
Yeah.
Some people, when we just walk in the door and just smile at them or hold their hand, they actually feel a lot better
Yeah.
with that. But there is a small percentage of people, maybe 15%, that still go to the emergency room.
Interesting.
And
okay.
so a lot of it's by choice. And
Right.
most of the people that do go to the emergency room, they're in and out within a couple hours.
Okay.
And I think maybe it's just a level of comfort.
Right.
Maybe there's a doctor there they like, they
Right.
treat them well, and that's what they know. But most of those people don't get admitted to the hospital. And the ones that do, and maybe there's 3 or 4% that do get admitted.
Right.
And they're usually kept for observation overnight,
Gotcha.
just kind of see
Just to
what's
make
going
sure.
on. Yeah, let's keep an eye on you.
Yeah.
So really, it's a safe program. The medical directors are all pretty satisfied with it. The customers are satisfied that they have options.
Right.
And when they don't, they don't need to go to the hospital, they don't incur those bills.
Right,
And if
absolutely.
the insurance doesn't cover it, then they've got to
Right.
pay out of pocket. So we
Yeah.
want to make sure that doesn't happen. We want to provide them with the best options altogether.
Right. Absolutely.
That behavioral health piece is
Yes.
the access plans now are looking for ways to treat behavioral health patients. They fall into this black hole. So I think
Right.
such an important
And
piece.
it's I don't know if it's our population because we have such a high population, or if it's just because there's more behavioral health issues nowadays that we know about nowadays that we didn't before. But I know behavioral health is very big on the forefront of everybody's
Even
mind.
in our seniors, I mean, it's just something 10 years ago that they wouldn't even talk about.
Right.
Right. So I think it's more. It's not as a taboo as it was 10 years
Right.
ago. Now they're more open to talking about because there's so many resources available. I think.
Absolutely, yeah. So when you're assessing someone, if someone calls 911 and you come out, and I've had this with my own family members, so I understand they've fallen and someone can't get them up, so you guys get called and you pick them up and you kind of check them out, make sure no bones are broken and things like that. Many times, at least in my family, they're like, I'm fine, I don't need to go anywhere. So that this program has probably helped some of that to make sure that they do get looked at by a physician of some kind, at some point. And then that way if they don't want to go to the hospital, they don't have to go. Is that correct?
Yeah, that's correct. This is all voluntary and it's choice. We just provide them with the different options. I like to refer to it as a menu because we used to only have one option on the menu, and that was hospital by ambulance.
Right.
But now with treat and refer, we've opened up other options and other opportunities. So when somebody falls, we'll go out and of course we'll pick them up. But it's the assessment and the vital signs and everything that we do to figure out what's going on with them. Is this new? Have you ever fallen? When's the last time you fell? And we actually do collect. There's some questions that we ask for the.
You have a good
falls.
database.
Yeah,
yeah,
to try to collect that data, and so we want to know if they have something going on that's new to them. Do they normally need assistance walking around or not? What kind of medications are they on? I just got this new medication, and well, maybe that's what's causing it.
Yeah.
We don't know, but we definitely try to do a thorough assessment there. And if we recognize they have injuries, skin tears, maybe they need sutures, or a wound needs to be cleaned, or there's bruising or swelling going on in an area, and maybe it doesn't need to go to a hospital. That's when we make that recommendation for urgent care. We can partner with Dispatch Health. Hey, just hang tight. Let's call. Let's get an estimated time of arrival and figure out what time they could be here. And if needed, they can order up X-rays and they can do the things that you need, clean your wound and kind of keep you at home, because sometimes when people go to the hospital, they pick up illness and bacteria.
They come home more sicker than when they. Yes, I totally
more
get
than
that.
they would at a daycare. And it's just not always a good environment. So
especially when their immune system's already weak to begin with.
That's so true.
Yeah. So now you have another program called ET3, correct?
Okay.
So tell us about that one.
Yeah. So ET3, it's not in place yet.
Okay.
We are currently applying for it. This is a CMS approved program nationwide, not just Arizona, but it's funded by Medicare fee-for-service and specific to Medicare fee-for-service. And so we're in the process of applying for it. The application is due in 30 days. And so we're working to get letters of intent from partners that want to participate in this program with us that we could refer patients to. So it's very much like treat and refer, but it's from an ambulance. So fire departments that have a certificate of necessity, that have ambulances and can provide transport, can apply for this service. And so when you get to the call, everything starts the same way, 911, do the assessment. And if there's other options for them, if they need transport, you can transport them to that facility, but they still have the medical necessity rule. So if they can't get there by any other means, they can't drive themselves or get another ride, and they need to go by ambulance, then you can take them by ambulance. However, the other options, we provide treatment on scene. So we do the assessment, provide treatment like we do with treat and refer. And there's a requirement that there either be a mid-level practitioner or higher, so a nurse practitioner or physician's assistant on scene, or we contact one through telemedicine. And so what we're doing is we're in the process of getting that established and partnering with a group of medical directors that can provide that 24/7 and have that consultation to ensure that the plan is safe and will work and be effective for the patient at that time. And then we'll arrange for transport for them to go somewhere else. However, there's still opportunity where mobile urgent care can come to
Right.
them as well.
Right.
And so that's how that program is going to
Okay.
run, but we're going to provide it for everybody.
Okay.
I know that CMS has been talking to the Medicaid payers in every state to try to get them on board so that
Okay.
Medicaid and Medicare can both participate. And then we're hoping the privates come along as well, because again, this is a much better service where we want to work directly with the payers.
Right.
Like treat and refer. With treat and refer, we don't bill anybody. There's no
Okay.
copay. There's nobody's going to collections over it. We want to work directly with the payer,
Right.
and we hope to do that with ET3 as well.
Okay.
And if they go to their doctor, it would be in network, or they work with
Okay.
urgent care. That
So this could be a huge, I mean, if this is, you're obviously including everybody and all insurances and all types of medical services that are out there.
yeah.
So,
Yeah, we want to get everybody on board and just change what we've been doing for years.
Right.
You know, the costs are just way too high,
Right.
and too many people going to collections and getting bills that they don't need when
or they're
there's other
not,
options.
or they're not going to the doctor when they
Right.
should
Yeah.
go
Because
to
of
the
that.
doctor.
Yeah,
That's
That's
because
another one. Yeah.
Yeah. So with this program, obviously you're still kind of in the planning stages of it. Do you see it coming on board anytime soon, or can you give us kind of a time frame as to?
Yeah, definitely. The way the program works is the applications close in 30 days.
Okay.
And then shortly after that, we'll find out who's approved nationwide. So they're going to approve ambulance providers and suppliers nationwide. That's
Okay.
private and public both.
Okay.
And once they're approved, there's another grant going out after that,
Okay.
and that's for dispatch centers. So
Okay.
municipalities that provide dispatch for multiple jurisdictions can apply. Now, there's only 40 of those going to be approved. So we're hoping that here in the Valley we have an opportunity to get one, because we're
Right.
all dispatched through the Phoenix Fire
Right.
Department.
Okay.
And so that would be a good opportunity for us to have that dispatch piece where they add or enhance triage on the front end. So when people call 911, there's a possibility where nobody needs to come out. Maybe they can
Right.
provide them with instruction for at-home care, or they can make a referral there over the phone to say, hey, you can, an urgent care can take care of you. Or if
Right.
needed, we'll send a low
Or
acuity unit.
or a home health care company or something
Yeah,
like that.
yeah.
Dispatch help.
Or dispatch help.
Dispatch help. Yeah, there's a lot of a lot of options. So they'll be applying and approved after the ambulances are, and then we're hoping by early 2020 these program will be available for everybody nationwide. And
Okay.
we're hoping that Surprise Fire Medical is one of the entities involved in that.
Okay, great. And do you think it would just be, well, you wouldn't know until it gets approved who's
Right.
going to be on it, but I'm
Yeah.
assuming Arizona will probably be on that list because we do have a high, a group of people of seniors out here.
Yeah,
so.
yeah, and with the treat and refer program being in place, a lot of what's in the application for ET3,
You're already doing.
we partnered like with the Health Information Exchange. That's one of our biggest partners there. So we so shared information is one of the biggest things. So when you go
Right.
to a doctor, they ask, well, who prescribed you this, or
Right.
and they don't have access to that information. But all that health information should live within that patient's portal.
Right.
And one of the references I've seen or similarities was, if you go out of state, you go out of town, anywhere, you go shopping, you buy stuff at one store, you go eat somewhere, you can look at your bank account
Right.
online and see where all the transactions have been and how much money's in there.
Right.
But with your medical health,
It's
you go to
not.
different places and
Yeah.
everything's siloed everywhere, and you can't go to one place. So that's why there's such a big push for that information living within the Health
Right.
Information Exchange.
Right.
So we've worked with them directly so that we
Okay.
can follow up with patients. We have a bidirectional exchange now,
Okay.
so our records live in the patient's
Okay.
records.
And I think that would be a huge help because I know that when I know my clients too, when they go to the emergency room, that's probably one of the biggest issues is getting patient from home through ER department into, say, neurotrauma where my daughter works, and getting the information to all those different entities
Yeah.
that are with them. And that's, sometimes you guys come in, the fire and paramedics come to the hospital and they drop everything off with that patient, and then maybe the emergency department somehow some of the information gets to their department, some of it doesn't. And so
Right.
there's got to be a system in place.
Yeah, so if everything's electronic and it lives and
Yeah.
it all goes to the same place, then it's always there. That would
Right.
minimize duplicate testing,
Right.
duplicate medications. It would increase safety, would reduce costs.
Right.
Overall, just a better system. And when we don't have to print a piece of paper, it's
Right.
less likely that
Yeah.
a piece of paper gets
Yeah.
lost or
Yeah.
left out somewhere, and then you have a HIPAA concern.
Oh,
So,
yeah.
if we can just share that electronically and have
Right.
everything live there, then
Absolutely.
it's much better.
And then the community paramedical, am I saying that right?
Community paramedicine.
Medicine.
Yeah.
Okay. So that is tell us what that program is. That's more of a follow-up program, right?
Yeah,
Okay.
so we had a community paramedicine program that was funded by Vitalis Health.
Okay.
There were 5 agencies in the West Valley that all partnered together. It was
Okay.
cities of Avondale, Goodyear, Peoria, Sun City, and Surprise. So we had 500,000 people that we could have as patients.
Right.
We had shared resources. We would team up a Surprise paramedic with a Goodyear paramedic, and we would reach out to patients that would utilize 911, that would call at least 3 times in a month or 12 times in a year.
Okay.
And so we're really trying to identify people that were reliant on the 911 system.
Higher risk people. it
Yeah,
sounded
yeah,
like.
high
Okay.
risk, but maybe they weren't. Maybe they just were using us as a form of primary
Utilizers.
health care. And so
I see. Okay.
we would make that appointment with them, come out, visit, spend an hour and a half with them, find out what health plan they belong to, what resources they have available,
Right.
and then help them get in touch with those resources. A lot of those folks had insurance, they just didn't have
They
a
didn't
primary
know.
care doctor. They
Yeah.
just didn't go to the primary care doctor, or they didn't fill prescriptions, or they had other challenges. Maybe it was a
Right.
behavioral health thing. They had
Yeah.
not talked to their behavioral health provider in a while, and so they needed to get back in there. One of the patients that we had in that program was a veteran and was calling 911 a lot for a lot of different things, but he was always doing okay. So when we set that appointment up with him and his family, we've discovered that really he wanted to have a service animal. He
Yeah.
really loved the dogs and wanted to have a service animal. And hey, I really, I get anxious. And so the family didn't know that. We discovered that. And the family actually just pitched in and got him one.
Wow.
And he stopped calling 911.
Yeah.
So overall,
yeah.
in that 1 year we ran that program, the patients that we identified, there were 78 patients that accounted for a couple thousand calls.
Okay.
We reduced their call volume by 89%.
Wow.
So-
and that's huge
Yeah.
for you
That's
guys
huge,
because
yeah.
then you guys can actually get the calls that. Not that these other calls aren't important
Yeah.
because they are, but
But,
if we
accidents
can
on the freeway.
Exactly.
I mean, those are the kind of things.
exactly, if we can
Yeah.
facilitate some of those lesser urgent calls to someone like Dispatch Health, you guys can actually go out to the major
Right.
calls that you have.
Yeah, once people are familiar with what they have available to them, and
Right.
it's like, you have a place where you like to buy your produce. You
Right.
go there, and you know that you have a certain pharmacy you go to. You're familiar with that, but not everybody's familiar with what they have. So
Right.
you try to help them with that. Maybe they're not following post-discharge instructions. Maybe just walking
Yeah.
down the street to the end of the block and back is what they what helps them and what they
Right.
need. So we really just want to get them more familiar with what they have, and
Right.
so they can rely on that when they need us. Definitely, they can call us anytime. We always
Right.
encourage that.
Right.
It doesn't matter what time of day it is. You call us if you need us.
Right.
We're there to help them. But this is just a way for us to help them by appointment, and so we can have more time, because most emergencies, 15 minutes. We try to figure out what's going on, try to figure out what's going on in their life,
Yeah.
with their body,
Because you have to
emotionally, and-
assess them quickly
Yeah.
to be able, depending on what their symptoms are, because like I know stroke victims
Mhm.
need they need certain medicine within a 3-hour window and things like that. So you guys have to basically assess them pretty quick.
Yeah,
right?
try to figure out quickly what's going on. Is this a
Yeah.
life threat or not? And if not, we can take a little more time on scene. But yeah, we just don't have the hour and a half to
Right.
really go through their social, physical, all their stuff that
Yeah.
a community paramedic can do. So that was a grant-funded program, and we're working on trying to get another grant. But what we would like to do is work with the payers directly, because when we Well, we have contracts with Medicaid payers for treat and refer.
Right.
And what we want to do is do the same thing is maybe get contracts with them. We have information, data we can share with them about
Right.
community paramedicine. We have stories we can share with them. And if they want to partner with us, we can definitely do that. We're not trying to replace anybody. Really, we're
Right.
just there trying to fill the gaps and the voids and get the
Right.
patients the appropriate level of care so they rely more on their primary care.
Right.
Or more on home health
and
or
to
whatever
make
it
sure
is they
that there's
need.
nobody being dropped through the cracks, because
Yeah.
that's what usually has happened over the
Yeah.
years is
Well, I think with ET3, it may bring some of those payers to the table, don't you think? And
Yeah.
I see
I
that there's
think
a
so.
lot of awareness around that.
Absolutely.
Yeah, with treat and refer being Medicaid and ET3 being Medicare,
right.
and being very, very similar in nature, I think there's definitely opportunity there, and that's what we're hoping for.
Right.
Overall, it would reduce costs and improve
Right.
health overall.
Right. So it sounds like Surprise and Arizona is almost the forefront of some of these programs that are going to be eventually implemented in other states. Is that
Yeah,
kind of what
yeah.
you're
Yep,
seeing out there?
Yep, that's definitely what I'm seeing. Arizona Department of Health Services, the
Okay.
medical directors here, Access of Arizona, Health Current, the HIE, they've all had a hand in this, and they've
Okay.
all been part of that, making Arizona one of the leaders in the nation.
Right.
For sure.
Right. So obviously you work in the city of Surprise, but as far as other fire and paramedic programs, you guys get together on a regular basis with some of the other municipalities throughout the Arizona? Do you try to share ideas and programs that have worked and haven't worked? And if they haven't worked, what hasn't worked? Do you get together with some of your other?
Yeah, so we meet every month. So we
Okay.
have it's called the EMS ROC, so
Okay.
Emergency Medical Services Regional Operational Consistency Committee.
Okay.
So all the Valley Fire Departments meet every month, and we go through an agenda, and we talk
Okay.
about things like emergency medical services,
Right.
training, certifications, paramedic programs, treat and refer programs, partners. We talk about payers that we've met with, special groups we've met with, and we talk about things that work in our communities that are
Right.
making things better, and then we put other municipalities in touch with them as well.
Yeah.
The protocols and guidelines that we work off of, they're all approved and consistent throughout, because even though different areas, different cities have special
Right.
needs or challenges that they have, for the most part, a lot of the protocols and guidelines are very similar
Okay.
and approved throughout the state of Arizona. So
Right.
we want to keep things available. We want to work together. If one agency is found success doing something one way, then we share that with everybody else, so
Right.
that everybody, if there's questions, hey, how do I do that? Or who did you talk to? Or where did you go for that?
Right.
Then we meet every month to ensure that we keep things consistent.
Right. And I'm assuming that you also include in those meetings some of the, like the Dr. Nayeri with the Fall Coalition, those
Yeah.
types of people that are
Yeah.
maybe overseeing how many falls Arizonans have a year, and how to assess those falls and how to try to avoid those types of things. So
Yeah.
you have a group of people that come together every month for those purposes.
Yeah, we do. So there's a fall preventions coalition. So Dr. Nayeri sends out a lot of information, meets regularly with folks at the Department of Health Services.
Yep.
So work with them. We've added some of their questions to our electronic patient care record, so we can keep track of when people have fallen, when was their last fall, and
Right.
things like that. There's about 3 or 4 questions that we
Yeah.
include in there to collect that data to share with the state. But
Yeah.
that and the EMS senior stakeholders group, that's another group we meet quarterly. And what we're doing there is we're working with care facilities
Okay.
to ensure that they know, hey, when 911 should be called, or when it should.
That's a
hey,
good one.
Here's
Big
here's
one.
other options. If it's
Yeah.
an illness that someone's familiar with, or a real minor injury, they
Right.
could get in touch with services like Dispatch Health. It's an
Right.
excellent service that can come out and provide them assessment, evaluation on scene. They might not need to go anywhere from there.
Right.
If it is something that seems more emergent, someone hit their head and maybe there's some bleeding going on, then definitely call us out and we can come out and evaluate. But we'll work with them. But when we do come out, then we will make those referrals as well. Hey, call these folks and they can help you out. So we're working with them so that we have an understanding and we share the list with them. Hey, we're here 20 times this month, or
and that includes group homes besides large facilities.
Yeah.
Is that correct?
Yeah. So any facility that seems to utilize 911 often, and there's some misunderstandings. We'll go and sometimes they think, oh, we can't pick them up, or we're not allowed to touch them,
right?
Because they fell.
I hear that all
you
I
have
do
to,
too.
You have to take
and
them to the
ask
hospital.
us if we can pick them up.
Yeah. So
it happens all the time.
Yeah. So we're just trying to straighten these things out. If they're a care facility, then they should be able to provide the care that patient needs. So really a lot of it's just misunderstanding.
Right.
And so
and my team is out in the field every day, and that's what we do. It's people
really
always
education.
ask us, why don't more people use you? Well, we've got to re-educate people and shift that paradigm, right? We're going to shift it, that call to 911, because that's the first place their brain goes, is 911, 911. So we're constantly reinforcing, maybe think about that first.
Right.
Is this, or just pick up the phone and call us.
Right.
And we'll walk
and find
you
out,
through.
is it an urgent call where it would take someone out of the field where an urgent call actually needs to be taken care of. So,
or it's going to put one of our frail seniors in the hospital for 2 weeks and really diminish them. So.
Well, this is a wealth of information, and I would love to have you both come back again, because I'd love to know how the program is going in a couple of months and see what changes you've made to the program, and if we've maybe expanded it to other communities within Arizona, because I see nothing but good out of this. I mean, I'm sure there's a lot of bumps along the way and what you can and can't do, but I look at it as we've got so many baby boomers in the state of Arizona, and that's probably the majority of your calls are probably a lot of the baby boomers, and we've got to rethink out of the box of how we take care of some of these folks, because there's just not enough caregivers and enough first responders and enough nurses and doctors in the hospital. We have a shortage of caregivers, basically, and so we need to rethink how can we take care of some of these folks and give them the services that they need. So I really appreciate you coming, and I would love to have you come back. So anytime you're available. So.
Definitely. Well, thank you very much for having me.
Yeah. Well, that is it for our podcast today. And next week we will have Kim Yates with Savior Hospice coming, and she will talk about the difference between hospice and palliative care. Thank you so much.
Thank you.